I'm going to start with a patient. This patient is suffering from dizziness, and listen to this gentleman. So let me get an idea about his problems. Mr. Dhanush, what are your major complaints?
मुझे बहुत चक्कर आते हैं। ये 6 महीने से कम ये प्रॉब्लम चल रही है। 1 साल और 6 महीने से ये प्रॉब्लम चल रही है कि मेरा सिर में काफ़ी दर्द रहता है, चक्कर सी फीलिंग आती है और ऐसा लगता है कि मैं नीचे गिरने वाला हूँ। तो इसके लिए मुझे काफ़ी सारे टेस्ट भी मैंने करवाने पड़े, बट फाइनली ये हुआ क्लियर कि एक तरह से वर्टिगो है, जिसमें मोर साइकोलॉजिकल रीजंस ज़्यादा है रादर देन कि कोई पैथोलॉजिकल रीज़न नहीं निकला इसका।
Okay, what do you diagnose? I was assuming that nobody of you is speaking Hindi. Therefore, I show this video. Why do I show this video from this nice IT specialist living in Munich, speaking Hindi? To show you how important the patient history is. Very simple. So, patient history, listening. This is something very easy for ENT doctors to listen to your patients, not only for psychiatrists and psychotherapists, but ENT doctors, they're close to the ear and they should really listen. So, why is it important to listen to your patients? Because, as I will show in a few moments, the diagnostic criteria of most of the vestibular disorders depend on the patient history. And this is what I meant in my introduction. There are 4 key questions which always have to be answered by your patient. And if the patient does not report that spontaneously, you have to go through them step by step. Very important. Otherwise, everything else does not make sense. So that's an absolute prerequisite for every diagnosis. So first, type of vertigo. That means, does the patient have, for instance, rotatory vertigo, like spinning around, like dancing a Venice waltz? Or does the patient have postural imbalance, dizziness, feeling unstable, like being on a boat or on a ferry? And as I said in the lecture on the anatomy, if you have a rotatory vertigo, this normally indicates a dysfunction of the semicircular canals. If you have a postural imbalance or dizziness, this most often indicates a sensory deficit, as in unilateral or bilateral vestibulopathy, but also in functional dizziness. So it's very important. I think the time course of the symptoms, the duration, is even more important. And there are 2 basic questions. First, does the patient have attacks? Or does he or she have a permanent problem? If a patient has attacks, you have to find out the minimum and the maximum of the duration. It sounds very simple, very trivial, and most helpful. Attacks can occur seconds. This is typical for vestibular paroxysmia, VPPV. Attacks can last many minutes to hours. Meniere's vestibular migraine, episodic ataxia. Symptoms begin abruptly, lasting several days. Vestibular neuritis, brainstem or cerebellar infarction. Patients with permanent problems, bilateral vestibulopathy, persisting unilateral deficit, psychogenic dizziness. That's all. The third aspect are modulators of the symptoms. Typically, changes head or body position relative to gravity, typical of BPPV, also central positioning like that. Sneezing, pressing, coughing, lifting heavy weights, typical of perilymph fistula. Symptoms are better in the early morning. Symptoms are better after small amounts of alcohol, 2 tequilas. Phobic postural dizziness. So ask for modulating factors, not only activating. But there are also some factors which can alleviate the symptoms. Then accompanying symptoms. They can be classified into three groups. First, arising from the inner ear, hyperacusis, tinnitus, fullness in one ear, typical of Meniere's disease. What is often neglected are accompanying symptoms typical for vestibular migraine, headache, hypersensitivity to light and sound. History of migraine is very important. So ask the patient explicitly for that, because normally they do not report that. They just feel dizzy, that's it. So you have to be the detective, Inspector Barnaby or the mentalist or Columbo, whatever you like. So you have to be like a detective. That makes a lot of fun. So it's not a crime story, it's a health story, and you have to work and act as a detective. And most of the time, you find the reason for the symptoms. And when it comes to accompanying symptoms like double vision, paresis, or ataxia, this indicates a serious problem, mainly a stroke or a bleeding in the brainstem or cerebellum. So these patients have to be immediately transferred to a hospital because they are at a high risk. So, why is the patient history so important? We have already seen this slide. Now we can go through different diagnoses. Phobic postural dizziness. It's based on patient history only. There's nothing specific you can find. Vestibular migraine, it's based on the patient history. Meniere's disease, audiogram plus history. As I'll show you the new diagnostic criteria as a classification committee by the Bereni Society. So for 6 vestibular disorders, we have new classifications. It's mainly based on the patient history. Bilateral vestibulopathy, you should measure something. Vestibular paroxysmia, patient history. So the majority of diagnosis is simply based on the patient history. Take 5 minutes, then you should have an idea. The next step is bedside examination. And there are 2 basic questions. First, is there a deficit at all or not? And this is an almost philosophical question, because according to Karl Popper, this famous Austrian English philosopher, a falsification is not possible. So you have to change your view and look specifically if there are any deficits. And we have some good tests in our hands. And the second question is, in particular in patients with acute vertigo, is it peripheral or central? And later on, I'll show you the big 5, which help you to differentiate between peripheral and central. So here you see an overview of the key features of the examination in patients with vertigo and dizziness. David C. already pointed out how important the examination of eye movement is and the cerebellum. And the first thing one can start with is a head impulse test, the HIT, or, as you will see, which I recommend, is the video HIT. Then you should look at the different components, and I'll explain that in more detail later, of the ocular tilt reaction, which you see in almost all patients with acute vestibular deficits. Look for the different types of nystagmus. David will talk about that in detail. And finally, you should examine stance and gait. And in the afternoon, David and myself, we will do a practical course on that, so that you can examine each other pairwise. You should not leave this hall without knowing how to examine a patient. Okay, now look at the head impulse. So some patients, you simply say if there is a deficit, or is it on the left or on the right side. Because the videos are running. So, which side is not working properly? Left and right. We will see in a few moments. Left side. Okay? Easy to diagnose. Okay, first patient. Second patient. See how quickly the test has to be done. Which side? Left side. Which side? Left side. So we will demonstrate how to properly do the test. And finally, the fourth patient. side? Left, right, and both? Both. Okay. So we have an alternative method which can be easily applied to measure the gain of the vestibular-ocular reflex? Yes, we do. And this is the video head impulse test. And if I had given this lecture 2 years ago, I said, head impulse test, the backside test is perfect. But during the last 2 years, I have changed my mind completely. And why? I'll show you in a few moments. So, this is now a well-established technique, the video head impulse test. There are two companies, Interacoustics, for instance, distribute, or Autometrics. They have their systems which are working equally well. And here you see how a recording is done. This is, by the way, Erich Schneider, who developed the system for Interacoustics. He's one of our engineers. And you see, that's a very simple technique. You measure the angular eye velocity and you measure the head velocity. And then there are different ways to calculate the so-called gain of the vestibular-ocular reflex. Simply, you divide the eye velocity by the head velocity. And normally it's above 0.8 or 0.7 or 0.75. We don't have exact data on that. If someone has one about 0.8, it's assumed to be normal. So very simple. You measure the eye movements, and here you measure the head movement, and this is divided by each other. Here you see a normal head impulse test in a healthy subject. So here are the head velocities in degrees per second. Here are the eye velocities, and normally the gain is close to 1. And this is important to keep the image of the visual surrounding stable on the retina. So here you see another patient. You see here the eye velocity. The head velocity goes up to 200 degrees per second, and you see the eye velocity is just 100 degrees per second. But what this patient is doing, even during the head impulse test, he's already performing a saccade. And this is so-called a covered saccade. You will not see it. And therefore you get the idea the head impulse test is totally normal. So this is a false negative finding. These are difficult patients, particularly if they have a vestibular deficit for a longer time. So if you calculate the gain, it's only 0.5 here after 80 milliseconds or after 60 milliseconds. But the patient makes a quick saccade and you don't see a pathological finding. Here's another patient. You see here, his eye velocity is almost 0. This patient has a bilateral vestibulopathy, so you can clearly identify the bilateral vestibular deficit. And we just looked at our performance. So MS is for Michael Strupp, CB is for a colleague from Singapore, who is a visiting scientist for 1 year, OT is for another colleague. We did 400 hits in 200 patients who just came to our hospital. And we did some elementary statistics on that. So we measured the sensitivity, the specificity, in particular the positive predictive value here, which is only 0.5. And you can also use a coin. So this is, and I think we are quite experienced in the field, so this is also reality. Bad news. So the head impulse test is only in certain patients really helpful. And then we looked at the VOR gain and looked if this was related to the VOR gain, and the findings did not become really better. So we go down to 0.7, 0.75, 0.8. We did not really improve. And here's another patient. How is that? What do you think? Normal or pathological? The head impulse test. You may say it's pathological, but this is a patient with cerebellar problem. And if you magnify, or have a video oculography, you look at the eyes, you see, it may look pathological. You would say it's pathological. But if you do slow motion recording of the same patient, you know what's wrong here. He has a perfect vestibular ocular reflex, but he has a gaze holding deficit, and then he makes a quick saccade, and this gives you the impression it's pathological. So a particular patient with cerebellar problems are often misdiagnosed as cerebellar plus bilateral vestibulopathy. So, to make this longer story short, I think for centers who see many patients with vertigo and dizziness, it makes sense to invest in a video oculography pattern pass system. It's really reliable. It takes only 1 minute to make a recording. I do it in every patient, just 1 minute. Calibration, 30 seconds, recording 1 minute, that's it. Very quickly. I have it in my office, every patient, tuck, 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 7 in one, 7 in the other direction will do the job. Coming back to these cerebellar patients, what they do, they have a normal VOR gain, but they do late saccades, as you can see here from the coding, which give the idea that they have pathological VOR. Now we move over to another issue, which I mentioned before, how to differentiate between peripheral and central vestibular lesions, which is important in particular in patients with acute vertigo who come to the emergency room. And I said before, you cannot exclude something, but you can look for central signs. And good news, more than 90% of all patients with central vestibular problems also have central eye movement. And one important aspect is the ocular tilt reaction. The second, to look if a patient has a spontaneous or a central fixation nystagmus. And the other one is look for ocular motor signs. And these are the so-called big five. And we already described that many years ago, how sensitive and specific these big five are to differentiate central from peripheral vertigo. In 2008, we had a patient in the JAMP on that. So, look for a vertical divergence, look for a central fixation nystagmus, for what David already showed, saccadic smooth pursuit. Another important sign is nystagmus beating in one direction and a gaze-evoked nystagmus in the other direction. And finally, in a patient with acute vertigo, acute nystagmus, and a normal head impulse test, we have good evidence that this is a central problem. So, skew deviation. You don't need any machines, you just need your hands on the diagnosis of skew deviation. So the most sensitive test, we will show that in the afternoon, is the alternating cover test. Just cover the patient's eyes with your hands and look if you see jumping eyes. If you see that in a patient with central, you can stop here. This patient has to be transferred to a neurological department. What do you see here in this typical Bavarian? Head position, head tilt, and a typical Bavarian mustache. Okay, what about the eye position? Do you see here anything? No, you wouldn't. But if you do the cover test, you can easily see this skew deviation. You should cover long enough, at least 5 to 10 seconds. The eyes need time to deviate, and then you can see this skew deviation. Look here, another patient. Do you see anything here? Eye position. You see? The left eye comes down. So the left eye is above the right eye, skew deviation. Very sensitive sign. You don't find it in all central lesions, but if you find it, it's central. And the most sensitive test, as you can see here, is the alternating cover test. Then do a CT, exclude bleeding, and the patient gets normally a spring thromboscopy. So, vertical divergence, clinical sign of a central lesion, as in this patient here, with a left-sided Wallenberg syndrome. Another sensitive sign is a deviation of the subjective visual verticality. We summarized that in this neurology paper, and from different studies, it turned out that in more than 90% of patients with an acute unilateral vestibular lesion, you have a deviation. You can use this machine, but you can also use this bucket test, as you see here. I got this from Ricardo. So it's very simple. If you like, I can send you an instruction, including the scale. Send me an email, you will get one. And then you can build your own bucket. So the bucket we will use in the afternoon. in our bedside examination. It's as good as a good and expensive machine. Very simple method. Patient looks into the bucket, and the basic principle is that the patient just sees this line and cannot orient on outside vertical lines, otherwise the test would not be sensitive. You can do it 10 times in one, 10 times in the other direction, in a pseudo-randomized way, and then you get a good idea about the patient's subjective visual vertical. If it's deviated, it indicates an acute lesion. Here, the view from the examiner's point of view. So the examiner should hold the bucket, and the patient tells the examiner what he or she thinks is his or her verticality. Before we do something, it has to be approved in animals, otherwise they're not allowed to use it in patients. Good. And here are 3 simple rules on the oculative reaction. First, if you have a peripheral lesion, let's say on the left side, or a lower brainstem lesion like a Wallenberg syndrome on the left side, everything is tilted ipsi versa to the left. If you have a lesion above the level of the vestibular nuclei, all the components are tilted contraverse. And third, as mentioned before, in patients with a peripheral lesion, you don't have a skew deviation. If you have a skew deviation, it indicates a central lesion. 3 simple rules. Now look at the subject here, related to David's topic. He's falling asleep. When you fall asleep, you make a slow and a quick movement. This remembers you of nystagmus. And the word nystagmus comes from the Greek term nystathein, which means falling asleep. And when you fall asleep, you have a quick and a slow movement. Which one is the pathological when you fall asleep? The slow one? The slow one. If you have a nystagmus, which one is the pathological? The slow one too. Because it drives the eyes away from your point of fixation. Keep that in mind. The direction, however, is given according to the quick phase because you can easily identify the quick phase. The pathological phase is the slow phase. If you have a downbeat nystagmus, the eyes drift upward and be downward. If you have a vestibular neuritis on one side, the healthy labyrinth drives the eyes in the opposite direction, and then you make a fixation. So, David will explain that in detail. I would like to demonstrate you now this new instrument. The paper in neurology will come out with a cover page of these classes, September the 30th. So you can have the regular Frenzel's classes, 800 gram, $400, but you can also have the M classes, and they are not inferior to the regular Frenzel classes. So these new M classes are based on the knowledge of a French physicist, Monsieur Fresnel, who developed special lenses for lighthouses. And we have used these special lenses not for a lighthouse, but to develop new glasses to examine the patient. Every patient has to be examined. Here you see the difference from the neurology paper, which is now open access. You see here the difference in the dimensions on the weight. So, why is it helpful to have such an instrument? Look here, this patient was looking straight ahead. He didn't have a nystagmus when he was looking straight ahead. In other words, he could suppress his nystagmus by visual fixation. Is this typical for a peripheral or for a central lesion when you are able to suppress your nystagmus? Peripheral. And now look at here on the right side, you will see another patient. She would like to suppress her nystagmus, but she's not able to do so. In this patient with a Wallenberg syndrome. And this is a typical central fixation. And therefore, it's important. She also has a skew deviation. She had a Horner syndrome on the left side. To use Frenzel's glasses in every patient, and you should also do the positioning maneuvers. And David will definitely explain the signal which we use for suppression of a nystagmus. It's retinal slip. Okay, now look at this patient here. how is his smooth pursuit? Is it smooth or staccatic? To the left or to the right? To the left. As David pointed out, asymmetries are very helpful to diagnose a central lesion. Staccatic smooth pursuit in one direction indicates a structural brainstem lesion. Now the same patient, while examining his gaze holding function, you see this tiny nystagmus beating to the left, and now he's looking to the right, and he has a gaze evoked nystagmus to the right. This indicates a gaze holding deficit. If he looks to the left and you see the nystagmus, this can be a mixture of gaze holding deficit plus spontaneous nystagmus, which becomes stronger when you look into the direction of the quick phase, according to Alexander's law. So examining in the opposite direction, that's helpful, and this is another clinical sign. Spontaneous nystagmus with gaze evoked nystagmus in the opposite direction indicates a central lesion. Now another patient, acute onset of vertigo, spontaneous nystagmus to the left, and we saw this patient before. You can easily diagnose the deficit on which side, right or left? Right side. Okay? Typical for acute vestibular neuritis. And now look at this gentleman's examination on the right side. Also an acute nystagmus, an acute vertigo, nystagmus quick phase beating to the left. And in a few seconds we should see his head impulse test. So there was no difference in terms of the symptoms, no difference in terms of the nystagmus, but in terms of the head impulse test. And the take-home message is, if you have a patient with acute nystagmus and a normal head impulse test, as you see here, which should be pathological on the right side, this indicates a central lesion. So, and these are the studies on this topic. We published the first study on that in 2008, and we looked at gaze-evoked nystagmus, Q deviation, head impulse test, and saccadic smooth pursuit, and could differentiate peripheral from central with a sensitivity and a specificity of 92%, and this was confirmed by the other trials. So, once again, how to examine a patient. Head impulse test, we will demonstrate later. Look for the 4 components of the ocular tilt reaction. Head tilt, Q deviation, rotation of the eyes is not so relevant, but deviation of subjective visual vertical is most sensitive. Differentiate peripheral versus central nystagmus. Examine eye movements and stance and gait at the end. And for those who are interested in the examination of eye movements, we just designed a new website. It's called neurocular.com, together with a Swiss company, Actelion. And there you see how to examine patients, and you see a lot of pathological videos. You will also see a glass brain with the different anatomical structures. You click on the glass brain, you see the physiological movement. You click on the glass brain and you see a gaze-evoked nystagmus or a vertical gaze holding deficit or a vertical gaze palsy. So this is almost ready, just the beta version. So, to summarize this longer story. First, patient history. Which types, which questions do you ask? What do you want to know? Type of vertigo, time course, modulating factors, accompanying symptoms. When you examine a patient, what do you look at? Four components of the ocular tilt reaction: vertical divergence, head tilt, Q deviation, eye rotation, subjective visual vertical. You do the head impulse test, and if you are lucky, you can do it with a machine. You examine all types of eye movements, as David demonstrated: smooth pursuit, gaze holding function, saccades. You do the positioning maneuvers. You look for a peripheral versus a central type of nystagmus with the ventral classes or the end classes, and at the end, stance and gait. Again, 5 minutes. 5 minutes patient history, 5 minutes examination will do the job. 6 patients per hour. Thank you very much for your attention.
Amigos, les invitamos al receso. Hay un desplazamiento del horario, 10 minutos. Estamos aquí de vuelta a las 10:30 en punto. Comenzamos el segundo bloque. Traten de estar un par de minutos antes, por favor.